Good evening, Dr. Phil here. Today we'll be discussing on cholinergic agonists, acetylcholine receptors. These are transmembrane receptors and are activated by acetylcholine. They are classified according to the relative affinity to muscarine and nicotine. Nicotinic acetylcholine receptors. These are ligand-gated ion channels. From highest to lowest affinity, it binds nicotine, acetylcholine, and muscarine. Nicotine at low concentration stimulates the receptor, while nicotine at high concentration blocks the receptor. Nicotinic acetylcholine receptors are located at neuromuscular junction, autonomic ganglia, adrenal medulla, and other areas in the CNS. Nicotinic receptors of autonomic ganglia differ from those of the neuromuscular junction. As an example, ganglionic receptors are selectively blocked by mecamylamine, whereas neuromuscular junction nicotinic receptors are selectively blocked by atracurium. Structure. Nicotinic acetylcholine receptors consist of 5 glycosylated protein subunits that form a cylinder around a central ion channel, spanning the postsynaptic membrane and projecting into the synaptic cleft. Adult acetylcholine receptor subunits includes 2-alpha, 1-beta, 1-delta, and 1-epsilon. Neonatal acetylcholine receptor subunits includes 2-alpha, 1-beta, 1-delta, and 1-gamma subunit. Binding of acetylcholine to acetylcholine receptor and its activation. This occurs at the 2-alpha subunits. Occupation of the 2-alpha site by acetylcholine opens the ion channel and cations, primarily sodium, potassium, and calcium, flows into the cytoplasm down their concentration gradients, and an excitatory postsynaptic potential is produced. After summation of these excitatory postsynaptic potentials, the threshold potential is reached and an action potential is generated. Depolarizing and non-depolarizing neuromuscular blockade, kindly refer to their respective videos for further details. Muscarinic acetylcholine receptors. These are G-protein coupled transmembrane receptors which are coupled to adenylate cyclase via GI protein or phospholipase C via GQ protein. Muscarinic receptors are activated by acetylcholine. Muscarinic receptors are located at autonomic effector organs such as the heart, smooth muscle, brain, exocrine glands, etc., at ganglia of peripheral nervous system, and in the central nervous system such as in the hippocampus, cortex, and thalamus. Muscarinic receptors in the autonomic nervous system mediates postganglionic neurotransmission via parasympathetic neurons and sympathetic outflow to sweat glands. Classification of muscarinic receptors is according to structural subtype, distribution, and function, and they can be classified as M1, M2, M3, M4, and M5. M1 receptors are mainly located at autonomic ganglia, including intramural ganglia in the stomach, gastric oxyntic glands which produces acid secretion, glands such as salivary or lacrimal, and cerebral cortex. Transducer is GQ, effector protein is phospholipase C which cleaves PIP2, second messenger is IP3 and DAG. IP3 produces increased intracellular calcium release. Calcium then interacts to stimulate or inhibit enzymes or to cause hyperpolarization, secretion, or contraction. DAG activates protein kinase C, which phosphorylates numerous proteins within the cell. Cellular response upon M1 activation is increased IP3, increased DAG, depolarization, excitation, slow excitatory postsynaptic potential, and reduced potassium conductance. Functions of M1 includes to stimulate acid secretion in the stomach, salivation, learning and memory formation, and regulation of locomotor activity. Non-selective muscarinic agonists includes acetylcholine, Carbachol, oxytremorin, Pilocarpine, and Bethanechol. Selective M1 agonist includes MCNA343. Non-selective muscarinic antagonists includes atropine, dicycloverine, tolterodine, oxybutynin, and ipratropium. Selective M1 antagonists includes pirenzepine and mamba toxin MT7. M2 receptors are mainly located at the atria of the heart and widely distributed in the CNS. Transducer is GI alpha. Effector protein is adenylyl cyclase. Second messenger is CAMP. Cellular response is reduced CAMP, inhibition, reduced calcium conductance, and increased potassium conductance. M2 functions to reduce heart rate, heart contractility, reduce AV node conduction, neural inhibition, central muscarinic effects such as tremor and body temperature regulation, producing hypothermia, and smooth muscle contraction. Selective M2 antagonists includes galantamine. M3 receptors are mainly located at exocrine glands such as salivary glands, smooth muscle such as in the GI tract, eye, airways, and bladder, and in the endothelium of blood vessels. Transducer is GQ. Effector protein is phospholipase C, which cleaves PIP2. Second messenger is IP3 and DAG. Cellular response to M3 activation is increased IP3, stimulation, and increased intracellular calcium. Functions of M3: increase smooth muscle tone, such as in the bronchioles, intestines, iris, and bladder. Increased gastric and salivary secretion. Stimulatory at vomiting center. Insulin secretion at pancreatic beta cells. M3 receptors are found on endothelial cells lining the smooth muscles of blood vessels. They have no known physiological function. If stimulated by IV acetylcholine, vasodilation and hypotension occurs from nitric oxide production. Selective M3 agonist is cevimeline. Selective M3 antagonist is derifenacin. M4 receptors are mainly located in the CNS. Transducer is GI alpha. Effector protein is adenylyl cyclase, which inhibits. Second messenger is CAMP. Cellular response to M4 activation is reduced CAMP and inhibition. Functions of M4. These are inhibitory autoreceptors for acetylcholine, activation of which inhibits acetylcholine release in the striatum, and this inhibits dopamine-induced locomotor stimulation. An example of selective M4 antagonist is mambatoxin MT3. M5 receptors are located in the CNS substantia nigra, salivary glands, iris or ciliary muscle, stomach, esophageal smooth muscle, and the heart. Transducer is GQ. Effector protein is phospholipase C, which cleaves PIP2. Second messenger is IP3 and DAG. IP3 causes intracellular calcium release and DAG activates protein kinase C. Cellular response to M5 activation is increased IP3 and excitation. M5 functions includes to stimulate gastric acid secretion. However, M5's function in other locations are unknown. Comparing muscarinic and nicotinic receptors. In addition to binding acetylcholine, muscarinic receptors also recognize muscarine, an alkaloid that is present in certain poisonous mushrooms. Muscarinic receptors show only a weak affinity for nicotine, unlike nicotinic receptors. Activation threshold of muscarinic receptors is lower than nicotinic receptors. The significance of this is that at injecting lower doses of acetylcholine or Anticholinesterases causes parasympathetic stimulation and muscarinic effects before having effects at autonomic ganglia and neuromuscular junction at higher doses. Drugs with muscarinic actions preferentially stimulate muscarinic receptors. However, at high concentration, they may show some activity at nicotinic receptors. Clinical effects. Muscarinic effects includes increase in exocrine gland activity resulting in lacrimation, salivation, rhinorrhea, bronchorrhea, hyperamylasemia, and sweating. Cardiac effects includes bradycardia, hypotension, and arrhythmias such as AV block, ventricular dysarrhythmias, idioventricular rhythm, etc. There is increased smooth muscle activity resulting in bronchoconstriction, bladder stimulation, incontinence and urination, sphincter relaxation, meiosis and blurred vision, increased GI motility resulting in vomiting, abdominal cramps, and diarrhea. Nicotinic effects includes muscle fasciculation, muscle weakness, and muscle cramping. CNS effects includes agitation, confusion, tremors, ataxia, seizures, and loss of consciousness. Examples of cholinergic agonists: directly acting cholinergic agonists, acetylcholine, Bethanechol, Carbachol. cevimeline, nicotine, and pilocarpine. Indirectly acting reversible cholinergic agonists includes Ambenonium, Donepezil, Edrophonium, galantamine, Neostigmine, Physostigmine, Pyridostigmine, and rivastigmine. Indirectly acting irreversible cholinergic agonists includes ecothiopate and organophosphate poisons. Reactivator of acetylcholinesterase includes pralidoxime. Cholinergic antagonists includes anti-muscarinic agents such as atropine, benztropine, cyclopentolate, derifenexin, physothiazide, ipratropium, oxybutynin, scopolamine, solifenacin, tiotropium, tolterodine, trihexyphenidyl, tropicamide, trospium chloride. Ganglionic blocker is nicotine. Neuromuscular blockers, kindly refer to the respective videos for further details. Acetylcholine. It is an acetyl ester of choline which functions as a neurotransmitter. It is a quaternary ammonium compound, therefore cannot penetrate membranes. Synthesis. Acetylcholine is synthesized from acetyl coenzyme A formed in mitochondria and choline, which is actively transported into the nerve. In the nerve-ending cytoplasm, choline acetyltransferase catalyzes the synthesis of acetylcholine from acetyl coenzyme A and choline. Acetylcholine storage occurs in neuron vesicles. Location of acetylcholine as a neurotransmitter. It is located at autonomic ganglia, parasympathetic postganglionic nerve endings, sympathetic postganglionic nerve endings, at sweat glands and some muscle blood vessels, at the neuromuscular junction, and in the central nervous system, where acetylcholine plays a prominent role in learning. Actions of acetylcholine. It is based on the type of acetylcholine receptor and can be divided into muscarinic and nicotinic, which has been discussed earlier. Acetylcholine thus causes nicotinic and muscarinic effects. Acetylcholine has a limited therapeutic role due to its lack of specificity in its action and rapid inactivation by acetylcholinesterase. Breakdown of ACH. It is hydrolyzed by acetylcholinesterase to choline and acetate at the postsynaptic membrane. Other esterases also cleaves acetylcholine, such as plasma cholinesterase, which will be discussed later. Bethanechol. Bethanechol is an unsubstituted carbonyl ester which is structurally related to acetylcholine. Metabolism of bethanechol. It is not hydrolyzed by acetylcholinesterase due to carbamic acid esterification. Other esterases inactivates it via hydrolysis. Actions of bethanechol. It lacks nicotinic actions due to addition of a methyl group. It has strong muscarinic activity, mainly acting on smooth muscles of bladder and GIT. It increases the tone and motility of intestines and triggers urination via detrusor muscle contraction and trigone and urinary sphincter relaxation. Duration of action is 1 hour. Therapeutic role of bethanechol. To stimulate atonic urinary bladder, such as during postpartum, postoperative, non-obstructive urinary retention, and neurogenic atony. Treatment of megacolon. Adverse effects. Effects of generalized cholinergic stimulation and muscarinic effects. Atropine may be administered to counter these muscarinic effects. Carbachol, also known as carbamylcholine. It is an ester of carbamic acid. Metabolism. It is not hydrolyzed by acetylcholinesterase due to carbamic acid esterification. Other esterases inactivates it via hydrolysis. Actions of carbachol, nicotinic and muscarinic, ganglionic stimulating activities as well. It first stimulates then depresses cardiovascular system and GI system. Adrenaline release from adrenal medulla via nicotinic actions. If instilled into the eye, just like acetylcholine, it will cause meiosis and spasm of accommodation. Therapeutic use of carbachol. It is a miotic agent for the eye to treat glaucoma. Adverse effects. If used as eye drops, it causes little or no systemic effects as it is not absorbed systemically. Pilocarpine. It is an alkaloid tertiary amine. It is stable to hydrolysis by acetylcholinesterase. It is less potent than acetylcholine and can penetrate the central nervous system at therapeutic doses. Actions: when applied to the eye, it produces meiosis to treat glaucoma. Pilocarpine is a potent stimulator of secretion production. Therapeutic use of pilocarpine: emergency lowering of intraocular pressure of both open-angle and closed-angle glaucoma by causing meiosis. The trabecular meshwork is open around the Schlemm canal, and an immediate drop in intraocular pressure occurs as a result of the increased drainage of aqueous humor. This action occurs within minutes and lasts for 4 to 8 hours. Repeated doses can be administered. Pilocarpine is also used in the treatment of mydriasis due to atropine and in the treatment of xerostomia caused by irradiation, Sjogren syndrome, etc. by promoting salivation. Adverse effects of pilocarpine includes blurred vision, night blindness, brow ache, and muscarinic effects if overdosed. Counter this by using IV atropine. Next, we move on to indirectly acting cholinergic agonists. Introduction. These substances indirectly provide a cholinergic action through increase of acetylcholine concentrations by inhibiting acetylcholinesterase. They are carbamate esters, which are water-soluble. They are quaternary ammonium compounds and are absorbed poorly from the GI tract, except for the more lipid-soluble Physostigmine, which is a tertiary amine, which can be administered orally as it is absorbed well from the GI tract. Physostigmine crosses the blood-brain barrier. Clinical uses of indirectly acting cholinergic agonists: reversal of neuromuscular blockade. When non-depolarizing muscle relaxants are no longer administered, recovery from neuromuscular blockade occurs. NDMR diffuses down a concentration gradient back to the plasma from which it is cleared. More acetylcholine receptors are stimulated from acetylcholine and recovery from neuromuscular blockade occurs. Administration of an anticholinesterase such as Neostigmine increases the half-life of acetylcholine at the neuromuscular junction, resulting in more acetylcholine receptors being stimulated by acetylcholine, and recovery is hastened. Examples of neuromuscular blockade reversal agents include Edrophonium and Neostigmine. Kindly refer to the video on neuromuscular blockade reversal agents for further details. Treatment of myasthenia gravis. For anesthesia and myasthenia gravis, kindly refer to the video discussing on neuromuscular junction. Examples of drugs used to treat myasthenia gravis includes Edrophonium, Pyridostigmine, Neostigmine, and Ambenonium. Treatment of the central anticholinergic syndrome. Pathophysiology. Relative or absolute reduction of cholinergic transmission in the central nervous system. Etiology. It is caused by overdose of drugs with anticholinergic activity such as atropine, hyoscine, antihistamine drugs, phenothiazines, antidepressants, anti-Parkinsonian drugs, and pethidine. It has also been reported after administration of volatile anesthetic agents, ketamine and benzodiazepines. It occurs in up to 5 to 10% of patients after general anesthesia. Clinical features of central anticholinergic syndrome includes confusion, agitation, restlessness, anxiety, amnesia, hallucination, speech disturbance, ataxia, nausea, vomiting, muscle incoordination, convulsions, coma, and peripheral anticholinergic effects, which includes tachycardia, dry mouth, dry skin, blurred vision, and urinary retention. Treatment is by slow IV Physostigmine. Dose is 0.5 to 1 mg in adults and 0.02 mg per kg in children. Physostigmine acts within 5 minutes and symptoms may recur after 1 to 2 hours. Anticholinesterases are also used to treat atony of the bladder and intestines. Examples include Physostigmine and Neostigmine. They are also used to treat dementia. Central depletion of acetylcholine in the cerebral cortex and hippocampus occurs in Alzheimer's disease. Anticholinesterases increases the concentration of acetylcholine and delays the progression of Alzheimer's disease. Examples of drugs used to treat dementia include tacrine, Donepezil, rivastigmine, and galantamine. Tacrine is hepatotoxic and has been replaced by other agents. Anticholinesterases, however, do not cure or reverse the process of neurodegeneration in Alzheimer's disease. Anticholinesterases are also used to treat cholinergic antagonist overdose, such as atropine, and in glaucoma treatment. Topical ecothiopate is rarely used for treatment of open-angle glaucoma due to its many adverse effects. Classification of anticholinesterases. They are classified as reversible competitive inhibitors, oxidiophoric inhibitors, and organophosphorus compounds. Examples of reversible competitive inhibitors include edrophonium and tetrahydroaminocrine. They prevent binding of acetylcholine by competitive inhibition at the anionic site of acetylcholinesterase. Examples of oxidiophoric inhibitors include neostigmine, Physostigmine, Pyridostigmine, and Distigmine. By acting as an alternative substrate for acetylcholinesterase, it produces a more stable carbamylated enzyme complex, which undergoes slower hydrolysis, and reactivation of acetylcholinesterase is thus slow. Organophosphorus compounds irreversibly phosphorylates the esteretic site of acetylcholinesterase. Inhibition of ACHE can last for weeks until new ACHE is synthesized. Examples of organophosphorus compounds include ecothiopate, parathion, and serine nerve gas. Mechanism of action. Anticholinesterases indirectly provide cholinergic action by preventing the degradation of acetylcholine. Acetylcholine accumulates in the synaptic space. These drugs provoke a response at all cholinergic receptors in the body, resulting in nicotinic effects, muscarinic effects, and CNS effects, which has been discussed earlier. Acetylcholinesterase. It is an enzyme located at the synaptic membranes of cholinergic synapses, neuromuscular junctions, red blood cells, and the placenta. It functions to cleave acetylcholine to acetate and choline and terminates acetylcholine actions. Release of choline. NCH3 moiety of acetylcholine binds to the anionic site of the acetylcholinesterase. The acetate end of ACH forms an intermediate bond at the esteretic site. Choline is liberated. Release of acetate. The intermediate substrate enzyme complex is then hydrolyzed to release acetate. Butyrylcholinesterases, also known as plasma cholinesterases. Old terminology. True cholinesterases refers to acetylcholinesterase. Pseudocholinesterase refers to butyrylcholinesterase, also known as plasma cholinesterase. They are produced by the liver and located in the plasma and other tissues such as the kidney and the brain. Physiological function is unknown. Anesthetic relevance. Butyrylcholinesterases metabolizes esters such as succinylmetonium, mivacurium, diamorphine, aspirin, ester local anesthetic drugs, propanidine, etc. Butyrylcholinesterases removes choline groups to produce succinyl monocholine and then succinic acid in the breakdown of succinylmetonium. Butyrylcholinesterases do not contribute significantly to the breakdown process of remifentanil and esmolol, which are instead hydrolyzed by non-specific cholinesterases. Administration of neostigmine or other anticholinesterases to a patient who is paralyzed with succinylmetonium will extend the duration of the neuromuscular blockade, as plasma cholinesterases are antagonized by anticholinesterases. Tacrine is a short-acting anticholinesterase that has been used specifically for this purpose. Other drugs that can inhibit cholinesterases include ecothiopate, cyclophosphamide, tetrahydroaminocrine, hexafluoranium, or phenazine. Prolonged action of drugs metabolized by plasma cholinesterases can occur due to decreased amount of normal plasma cholinesterases or inherited atypical plasma cholinesterases. Kindly refer to the video on succinylmetonium for further details. Adverse effects. Anticholinesterases augments depolarizing neuromuscular blockade. They can cause cholinergic crisis. Overdose of anticholinesterases results in effects induced by excessive acetylcholine and results in muscarinic effects, nicotinic effects, and CNS effects, which are discussed earlier. Respiratory failure occurs due to bronchoria, respiratory muscle weakness, and hypoventilation of brainstem origin. Shock can occur due to hypovolemic causes such as GI losses and exocrine gland hypersecretion. Cardiogenic shock can occur due to bradycardia, hypotension, arrhythmias, and heart failure from respiratory failure-induced hypoxemia and hypercarbia. A useful mnemonic is sludge gem, which stands for salivation, lacrimation, urination, diarrhea, GI upset, emesis, and meiosis. To differentiate myasthenic crisis in myasthenia gravis from cholinergic crisis, administer IV Edrophonium 2 mg, which will improve symptoms of myasthenic crisis and worsen or have no effect on symptoms of cholinergic crisis. Administer anti-muscarinic agents such as atropine or glycopyrronium to reduce effects of increased acetylcholine at muscarinic receptors. Centrally acting acetylcholinesterase inhibitors such as Donepezil, rivastigmine, and galantamine, used for symptomatic treatment of Alzheimer's dementia, have several adverse effects such as nausea, vomiting, fatigue, muscle cramps, increased creatinine kinase, convulsions, bradycardia, confusion, augmentation of depolarizing neuromuscular blockade, and antagonism of non-depolarizing muscle relaxants. Effects of anticholinesterases at ganglia are minimal at normal doses. Common reversible anticholinesterase agents. The reversible acetylcholinesterase inhibitors can be broadly classified as short-acting or intermediate-acting agents. Edrophonium. It is a quaternary amine, prototype short-acting acetylcholinesterase inhibitor. It binds reversibly via ionic bonding to the active center of acetylcholinesterase, preventing hydrolysis of acetylcholine. Onset of action is 1 minute. It has a short duration of action of 10 to 20 minutes due to rapid renal elimination. Actions are limited to the periphery. Clinical uses and doses. Prior to administration of edrophonium, ECG should always be monitored. Atropine must always be available. It is used for reversal of neuromuscular blockade caused by non-depolarizing muscle relaxants. Effectiveness of edrophonium for this indication is less predictable than with neostigmine. In equipotent doses with neostigmine, edrophonium has less muscarinic effects. The degree of neuromuscular block may increase after an initial period of recovery due to its short duration of action. The dose is 0.5 to 0.7 mg per kg, with IV atropine 0.02 to 0.04 mg per kg. Edrophonium is also used for the diagnosis of myasthenia gravis. Antibodies to the nicotinic receptors at the neuromuscular junction causes their degradation. Fewer acetylcholine receptors are available for interaction with acetylcholine. IV edrophonium leads to a rapid increase in muscle strength in myasthenia gravis. This test has low sensitivity and specificity. Excess edrophonium may initiate a cholinergic crisis. The dose is IV 2 mg followed by 8 mg if no adverse effects. Edrophonium is also used to predict patients' response to longer-acting anticholinesterases. It is used to differentiate cholinergic and myasthenic crisis. The dose is IV 2 mg 1 hour after the last dose of cholinergic drug. There is increased muscle strength in myasthenic crisis and decreased muscle strength in cholinergic crisis. Edrophonium is also used for the treatment of supraventricular tachycardia at the dose of IV 5 to 20 mg and in the diagnosis of dual block with a dose of IV 10 mg. There is increased muscle power in dual block. Neostigmine. It is a synthetic compound first synthesized in 1931. It is a carbamic acid ester, quaternary ammonium compound, thus it does not cross the blood-brain barrier and is poorly absorbed from the GI tract. Neostigmine methyl sulfate is administered parenterally. Neostigmine bromide is administered orally. Storage. Neostigmine is stored in brown vials as it disintegrates when exposed to light. Mechanism of action. It inhibits acetylcholinesterase by combining reversibly with it by formation of an ester linkage. Sustained inhibition of acetylcholinesterase occurs due to the prolonged process of hydrolysis of neostigmine after it binds to the anionic site of acetylcholinesterase and then to an esteritic subsite. Neostigmine also increases acetylcholine release via its presynaptic actions. Increased acetylcholine concentrations from acetylcholinesterase inhibition results in activation of nicotinic and muscarinic receptors, resulting in muscarinic and nicotinic effects, which are discussed earlier. Neostigmine also has a direct stimulatory effect on skeletal muscle acetylcholine receptors. It can cause depolarizing neuromuscular blockade in overdosage. Overdosage can also cause cholinergic crisis. Effects on autonomic ganglia. The effect is small. There is stimulation at low doses and depression at high doses. There are few CNS effects as it does not cross the blood-brain barrier well. Onset of action is 1 minute. Time to peak effect is 10 minutes. Duration of action. For IV neostigmine it is 20 to 30 minutes. For oral neostigmine it is up to 4 hours. Elimination half-life is 50 to 90 minutes. Neostigmine is largely excreted unchanged through the kidneys. Clinical uses of neostigmine includes to stimulate the bladder and the GI tract, such as to treat post-operative ileus and urinary retention, reversal of neuromuscular blockade by non-depolarizing muscle relaxants. Effect on skeletal muscle is greater than that of physostigmine, and it can stimulate contractility before it paralyzes. Neostigmine is also used to manage symptoms of myasthenia gravis. However, oral neostigmine is poorly absorbed from the GI tract, thus it is unsuitable to be used to treat myasthenia gravis. Neostigmine has been used as an adjunct to spinal anesthesia. Intrathecal neostigmine confers analgesic effects via stimulation of muscarinic receptors in the rex laminae 2 and 3 of the spinal cord. Dose-dependent nausea occurs. Dose. For reversal of non-depolarizing neuromuscular blockade, the dose is IV 0.04 to 0.08 mg per kg. To reduce unwanted muscarinic and nicotinic adverse effect, administer with either IV atropine 0.02 to 0.04 mg per kg or IV glycopyrronium 10 to 20 micrograms per kg. Titrate the dose to the degree of residual neuromuscular block. The dose for myasthenia gravis is 15 to 30 mg orally or 1 to 2.5 mg subcut or IM 2 to 4 hourly. The dose for other uses is as for in myasthenia gravis. Adverse effects of neostigmine includes muscarinic and nicotinic effects. It does not cause CNS effects, and it is not used to treat central anticholinergic syndrome. Simultaneous administration of an anticholinergic agent such as atropine or glycopyrrolate reduces neostigmine's cholinergic effects. Contraindications for neostigmine includes intestinal or urinary bladder obstruction, hypersensitivity, peritonitis, doubtful bowel viability, bronchospasm. Neostigmine should not be administered if zero twitches are observed on a peripheral nerve stimulator after administration of a non-depolarizing neuromuscular blocking drug or after succinylmetonium administration. Use with caution in patients with coronary artery disease, cardiac arrhythmias, bradycardia, recent acute coronary syndrome, recently sealed off colonic perforation, in patients with recent intestinal anastomosis, epilepsy, vagotonia, hyperthyroidism, peptic ulceration, Parkinsonism, or during cyclopropane or halothane anesthesia. Physostigmine. It is a tertiary amine. It is a natural alkaloid derived from West African calabar bean. It is also known as acerine. Acetylcholinesterase is reversibly inactivated by physostigmine after it forms a relatively stable carbamylated intermediate with acetylcholinesterase by binding to its esteritic site. It has an intermediate duration of action of 30 minutes to 2 hours. It is metabolized by non-specific plasma esterases. Physostigmine is more lipid-soluble than other carbamate esters, and it is absorbed more easily from the GI tract and crosses the blood-brain barrier. Actions of physostigmine includes muscarinic effects at the autonomic nervous system, nicotinic effects at the autonomic nervous system and neuromuscular junction. Physostigmine lacks a quaternary ammonium group unlike neostigmine and pyridostigmine, allowing it to cross the blood-brain barrier. Clinical uses of physostigmine includes to treat atony of bladder and intestines, to treat central anticholinergic syndrome. It is used topically in glaucoma. It is used to treat gamma-hydroxybutyric acid poisoning. It has been used as a general CNS stimulant to treat tricyclic antidepressant drug poisoning and to reverse opioid-induced respiratory depression. Physostigmine is no longer available in the UK. The dose is slow IV 0.04 mg per kg. Adverse effects: seizures if high dose, bradycardia, decreased cardiac output, skeletal muscle paralysis, other muscarinic or nicotinic effects. Pyridostigmine. It is the pyridine analog of neostigmine. Compared with neostigmine, it only has 25% potency of neostigmine. It has weaker nicotinic action on voluntary muscle. It has less muscarinic action on viscera. Onset of action is 15 minutes. It has a longer duration of action of 4 to 6 hours. Clinical uses. It is the preferred agent for treatment of myasthenia gravis. It is not suitable for reversal of non-depolarizing neuromuscular blockade as it has a prolonged onset of action. Half-life is 3 to 4 hours. The dose is 30 to 120 mg orally 4 to 12 hourly, up to 1.2 grams per day. Adverse effects are similar to those of neostigmine. Ambenonium. Like pyridostigmine, it is used in the chronic management of myasthenia gravis. It has a long duration of action of 4 to 8 hours. Adverse effects are similar to those of neostigmine. Donepezil, rivastigmine, and galantamine. These drugs are approved by NICE for the treatment of mild to moderate dementia. Patients with Alzheimer's disease experience a deficiency of cholinergic neurons in the CNS, and these medications increases CNS acetylcholine. However, none can stop the progression of Alzheimer's disease. GI upset is their primary adverse effect. Donepezil is a selective inhibitor of acetylcholinesterase. It has no effect on plasma cholinesterase. It has a long half-life and can be given daily. Rivastigmine inhibits both forms of cholinesterase. It has a shorter half-life, thus it is given twice daily. Galantamine is a cholinesterase inhibitor. It is also a presynaptic nicotinic modulator, of which clinical significance is unclear. Tacrine is first to become available, but it is replaced by other drugs because of its hepatotoxicity. Irreversible anticholinesterase agents, kindly refer to the video on organophosphate poisoning coming soon. These are my references. Thank you.